Hello, everyone. My name is Elizabeth Silver. I am the current Clinical Toxicology Fellow here at the Georgia Poison Center, and I want to thank you all for listening in on this presentation titled Pediatric and Adolescent Poison Education. As a brief overview, we're going to be discussing what poison centers are and specifically what the role of the Georgia Poison Center plays for the state of Georgia, and then we'll be going through two specific patient populations. The pediatric patient population, known as patients who are less than 6 years of age, and the adolescent patient population, patients that are typically between the ages of 13 to 17 or so. And then we'll wrap up the presentation with some poison prevention tips. Now, poison centers are an important public health entity because they serve as a resource for both public health, for the layperson, for people at home, people at work, but also for healthcare facilities. So they have a vital role in both the prevention and treatment of poisonings. And they also help to save the healthcare system money. Poison centers are not revenue generating. They save money. They can keep patients at home and they can manage patients who are already poisoned in the most cost-effective and efficient manners. All calls that come to poison centers are completely confidential. All poison centers are free to the public, and they are a 24/7 service, 365 days a year. There is always someone who is there and ready to pick up the phone and answer the call, whether it's someone calling from the home for their 2-year-old who just got into all of their siblings' multivitamins, or if it's from a doctor who's calling in from a patient who just overdosed on his antidepressant or antipsychotic medication. And we have help in more than 150 languages, and we even have resources for the hearing impaired when they call as well. The Georgia Poison Center functions like all these other poison centers in that it is still a public health entity. We provide the poison treatment and prevention advice for people calling from the home, from work, from schools. We also obviously give information to healthcare professionals to help in treating these poisonings. We have also pill identification numbers, drug information. We get a lot of calls relating to that. Some examples that are pretty common include breastfeeding mothers call a lot regarding medications that they want to take, but they're unsure if it will affect what goes into the breast milk for their child. We get a lot of drug identification and drug information questions, and what's unique about the Georgia Poison Center compared to some other ones is that we actually take rabies exposure questions for the Department of Public Health. Unlike other poison centers, they can actually call us, people in the state of Georgia who are scratched or bitten or think that they may have been exposed to an animal that has rabies. And we actually have algorithms, and we are able to determine whether or not the patients need to receive post-exposure prophylaxis. So all in all, we are actually one of the busiest poison centers in the nation. We are always in the top 5 of the busiest poison centers. We take about 75,000 exposure calls. So these are calls relating to someone who got into some type of medication or they are exposed to some chemical. And then adding up all the other calls we take, the drug information, the pill IDs, and the rabies questions, we have around 110,000 calls per year just in the state of Georgia. And there are multiple types of exposures, as I was briefly alluding to. Many people have a preconceived notion of what a poison is. They think about heavy metals, they think about arsenic, they think about medications that you get from the pharmacy. But really, Paracelsus, who's pictured here in this statue, he's considered the father of toxicology. He has a great summary for what we believe poisons are, and that is everything. And he's noted for quoting, "What is there that is not poison? All things are poison, and nothing is without poison. Solely the dose determines that a thing is not poison." And this is exactly true. Every single thing that we are exposed to has the potential to cause toxicity in a high enough dose. So we have things like antifreeze that we know we're not supposed to ingest. This is a good definition of what we may think of as poison. But then we have medications, whether it's over the counter, behind the counter. There are many other chemicals that we have in our homes that we use that we may not think of as being toxic until something happens. There's environmental toxins, things like berries, mushrooms, plants, and even things like carbon monoxide, a gas that you can't smell, you can't detect, it's not irritating. All these things are considered toxic. And it's important actually to realize the type of calls that we get at the Georgia Poison Center relating to these different exposures. We have the majority of our calls, as we can see here, for the age distribution, 50% of them are pediatric patients, less than 6 years of age. And then when we account for some teenagers and some older children ages 6 to 12, it's still over 60% of the patients that we get called about are children to adolescents, the remainder being adults and then older adults. And also looking at where we get these calls, the majority of them, over 70%, are starting from the home setting or the school or work setting. About 20 to 30% comes from the healthcare facility, but that's really important. The majority of our calls are coming from pediatric patients, and the majority of them are coming from the home. And this is where poison centers impact the cost of the healthcare system substantially. Because we have so many patients that come from the home setting, our recommendations for what's considered safe and when patients can stay at home helps us to save the healthcare system costs on transportation with ambulances, for admissions to the ED, admissions to the floor, and general recommendations that would cost money for lab draws and other types of imaging studies. We know what is considered to be toxic in certain amounts and different medications and based on the weight of the patient, so we have a huge impact on the cost just looking at this exposure distribution. And before we go into the very specifics and nitty-gritty on the two different patient populations, we have a general overview of the pediatric and adolescent patients we'll be discussing. Now, the pediatric ingestions are primarily unintentional. That's because pediatric patients less than 6 years of age, they're exploring the world with their mouths. Everything, especially once they get around 18 months, they have a better developed hand-eye coordination, and everything they see has the potential to go into their mouth, which means that they're just putting things in there and they don't know what it actually is. There's the issue with look-alike medications and chemicals. They don't know the difference between a pill and candy, or Pine Sol, a cleaning product, and their apple juice. And another really important thing to consider are dosing errors that come from the parents, because these children are not dosing themselves as we do as adults. The parents are typically using liquid formulations, especially when they're young, and depending on what type of measurement tool they get, if it's different, if they have other measurement tools at home, it's easy to make a dosing error. The most common dosing error is a decimal point error that occurs. And this is when, for example, you're supposed to give a half of a milliliter or 0.5 ml, and instead they get 5 ml. They move the decimal point over one place and get 10 times the allotted dose. It's actually one of the most common errors that we see. On the other side of the spectrum, we have the adolescent patient population. And these ingestions can be unintentional. We do have a lot of patients that call in where their parents accidentally give them the other sibling's medication. And so this is pretty common. But now we're getting into the intentional route, intentional exposure to medications or drugs or some type of substance, whether it's for abuse or for suspected suicide and self-harm. And this is an important concept to understand because suicide is the leading cause of death in patients aged 10 to 24 years of age. And we're also going to be discussing that there are multiple drugs of abuse that adolescent patient populations begin to expose themselves to. And we'll be discussing what some of those are and some of the effects that we'll see. But we're going to start off with the pediatric exposures for right now. And this is actually a chart that we've had showing the different common types of exposures that we see for all human exposures, pediatrics, adolescents, adults, and older populations, and then what just the pediatrics get exposed to. And we can see here that for pediatrics, cosmetics, personal care products is #1. And a lot of this is because we don't necessarily think that this could potentially cause any harm, and these products are left out, whether it be someone's makeup, foundation, or a lotion, or some type of bath or shampoo product. These are all things that are very, very easily accessible that children can reach that we don't consider to be toxic because we know not to eat it. But when the parent's 2-year-old puts the foundation in their mouth, they realize, oh, I don't really know what happens if I eat this. And so they call the poison center. Along the lines, we have household chemicals, different pain medications, analgesics, especially Tylenol or acetaminophen being the most common. And the biggest difference is there's not many prescription drugs on the pediatric list as opposed to the all-human exposures like the antidepressants or sedative hypnotics like Ambien or Wellbutrin we have on there. We don't quite get as many of those. We have more of the household products, cleaning supplies, foreign bodies, and toys that children just stick in their mouth. And the lookalikes, as I had alluded to earlier, are also really important to know because children are not going to be able to tell that difference. These are some great examples of the lookalike medications and substances that you may have in your home and not necessarily know the difference. So here we have some pine sol. Children don't know the power of pine sol and the difference that is between this white grapefruit juice or their apple juice that they're used to drinking. We have gummies here, and I honestly can't tell you which one is the normal gummy bear versus which one is supposed to be the multivitamin gummy. One actually interesting thing that we're seeing is not only are there multivitamin gummies that kids get into, but now we have the edible CBD gummies that children are getting exposed to that cause a bit more effects than the normal multivitamin compared to a regular gummy bear. Here we have some other candy. We have some jelly beans that may look similar in color to these iron tablets. And iron actually used to be one of the most common sources of pediatric poisoning and severe mortality until around the late 1980s when child-resistant packaging came about. And so even though these jelly beans, they look like the buttered popcorn flavor that I personally never eat, children may like that, and they may mistake the iron tablets for being the jelly beans. And then this is my favorite. We have a Hershey's chocolate bar or a laxative, which looks very similar. And I can tell you that my love for chocolate, I would have gotten into this as a kid and taken a big bite without even a second thought. However, there are medications that we are concerned about. The good news is that with pediatric populations, because they are typically tasting the world with their mouth, they may not get into a lot of a substance. Usually one pill or a sip of something, and they get deterred, especially if it doesn't taste good. They're not going to keep drinking the pine sol that was shown earlier. However, there are still medications and pills that even just one of them can cause severe detriment in these children, where if there's even the thought that they could have swallowed one, we're going to send them in for observation. And these are on the quote-unquote one pill can kill list. And so some of these medications I have listed here. Glipizide, this is an anti-diabetic agent, and it actually can cause patients to have low blood sugar. Children especially can have severely low blood sugar, which could cause a lot of complications. They start acting funny, and it can also be delayed. It doesn't have to be an immediate effect. A lot of times the glipizide is prolonged in their action, so it's delayed and it lasts a long time. And these patients need at least 24-hour potential observation in the hospital if they develop these symptoms. Clonidine is another medication that we see for a few different uses. It's used for ADHD. It's also used for blood pressure control. Patients who have high blood pressure, and there's a lot of forms of it. We have a patch formulation, we have a pill formulation, and this can cause very low blood pressure and low heart rate in children, and they need to be observed for a long period of time. Diltiazem is another agent for high blood pressure. Diltiazem is typically given in a pill. There is some IV formulations, but it's typically very long-acting and sustained release. And so patients, once again, they may actually not develop symptoms for a few hours and then start to feel worse and worse and worse and have very low blood pressure and low heart rate. Camphor is a substance that is no longer in quite as much over the counter. The FDA has regulated that it can only have up to 11% camphor in products. But you may know it for the kind of the nice smell that it has. It's been known to cause seizures in patients who ingest this, especially pediatric patients. Usually they're self-limiting, but there have been case reports of prolonged seizures. And so we do have a number in which we know from a mg per kg standpoint what would be enough to send that child in. Methadone is an opioid that is very long-acting. It's used for not only pain, but also for opioid use disorder. And patients who ingest one pill of methadone or get into this are also going to need to be observed for a very long period of time for their decreased CNS or nervous system, their decreased breathing and respiration. And then finally, we have amitriptyline. And amitriptyline is a medication, part of an antidepressant class, known as tricyclic antidepressants. And this is a dangerous class of medications, not only for pediatrics, but for all patients, for adults and adolescents alike, especially in an intentional overdose. But pediatrics don't need to take an intentional amount. They can just have one pill to have the effects of amitriptyline and have disturbances in their heart and other parts of their body as well. So the biggest thing that we can do for the pediatric patient population is prevention. As these patients are typically unintentional, they're exploring the world, there's a lot that we can do as family members, as mothers, fathers, and as healthcare professionals for recommendations of how to prevent the kids from getting into these things in the first place. Number one is securing these medications, especially when you have one of those pill boxes, you know, the pill minder boxes, the Monday through Friday, when you put those in there. Many people, you know, they'll have their prescription from the pharmacy and they'll take off, you know, the top of it from the child-resistant container. They'll store it away, but they'll leave the pill box out on the table or on the counter. And those are not child-resistant. It's very easy for a kid to get that down and pop open a top and just start eating what's in there. And while some medications, if they just get Monday or Tuesday, it won't be a big issue. If one of those is a glipizide, if one of those is a diltiazem, it only takes one pill to cause the effects in these children. And so it's important to remember to store these away and ideally use the child-resistant packaging if you can. Child-resistant does not mean child-proof. The way they define child-resistant is they've done studies in determining the age of the kid. If the child-resistant packaging can keep a child, for example, age 5, out of the bottle for 15 minutes, then it's considered child-resistant packaging, and this is in 85% of cases. So you can still get into a child-resistant container. It just helps to give you some time as a parent or babysitter to actually catch them before they can open it. Try not to leave products unattended. Things like the Pine Sol, things like your lotion or shampoo that's out and easy for access. These things, we may not think about it too much, especially if we know it's poisonous, like antifreeze in the garage, but the kids don't know not to ingest that. The third one is really important. This is double checking the dosing of the different measurement devices. And this is extremely important because the kids are not dosing it themselves. It's going to be a school nurse. It's going to be the parent, the guardian, someone who's dosing this medication for the child. And as I said before, the most common dosing error we have is a decimal point error. And so when you pick up that medication from the pharmacy, ask the pharmacist to show you how to get the medication out. Ask the pharmacist to show you how to measure, because it may be different before. It may be a syringe that attaches onto the bottle, or it may be the combination spoon syringe that you can sometimes get. Some people still use tablespoons from the actual spoons in their home, which is not a good way to measure the medication. And so double checking those measurement devices is going to be important to make sure that you don't have the dosing error. And this is also very important when you have multiple children that you're dosing different medications and using different dosing devices. And then finally, never call medicine candy. That's just going to be good practice going forward. If they think it's candy, they don't think there's anything wrong with that. Kids like candy. They want to eat candy. If you call medicine candy, you might get them to eat it for a bit, especially when you have, the multivitamins, whether it's the Flintstone chewables or the gummies, but then if they associate it with candy, and if they can get into it, they're just going to gobble it right down. Now we're going to be moving on to the adolescent exposure patient population. And for this, I'm going to be going into the different drugs of abuse that we can discuss and some of the effects. And it's important to realize that there are more than just the illegal drugs of abuse that we think about. Drugs of abuse can come in multiple forms. We have the over-the-counter drugs of abuse. One of the biggest ones being the cough and cold preparations, the cough syrups. These can have not only alcohol in them, they have other products like dextromethorphan that can cause effects. And so it's very easy to find information on this online, especially for the adolescent patient population. We have prescription medications. Prescription drug abuse is still drug abuse, whether it's their own prescription or it's someone else's prescription. There are still many medications that teenagers can get into that are prescriptions that can be abused. And then, of course, we do have the illegal substances that we think about, like heroin or meth and stuff that we can get off the street, ecstasy, for example. These are all things that are illegal, and the first things that pop to mind when we think of drugs of abuse, but just a reminder that there are more than this out there. So here are some of the common drugs that I will be discussing today. We have things like nicotine, alcohol, opioids, and then we have inhalants, marijuana, and stimulants. I'm going to be going through a little bit of each, provide some background information, and a bit about the presentation of the patients and why we're worried about these drugs of abuse. That the adolescent patient populations are more likely to be getting exposed to. So tobacco and nicotine products. Nicotine is the active ingredient in these tobacco products, and we know that there are multiple forms of tobacco. Typically, the biggest one we think about is cigarette smoke, and tobacco and nicotine products are one of the most heavily utilized drugs in the United States, especially in also parts of Europe as well. And when we think of cigarette smoking, there's so much more than just nicotine that's in there that we're worried about. Nicotine provides the addictive potential, and that keeps that teenager, keeps that patient going back and back and back to the nicotine, to the cigarette, or to whatever type of exposure that they have. But there's more than just that. There are over 4,000 chemicals in these tobacco products, especially when you think of the cigarette smoking and cigars. And the smoking can cause a lot of issues in and of itself. Not only are you addicted to these products from nicotine, but inhaling these different chemicals and the smoke and particulate matter for a long period of time causes a lot of respiratory issues, chronic coughing and phlegm production, increased risk of having infections, cancer risks that occur, and also heart issues and cardiovascular effects. There's been many studies of cigarette smoking we know is attributable to a lot of different preventable disease states. And this is really important to recognize in the adolescent patient population because the majority of patients that you see now that are adults that have been smoking cigarettes typically are exposed to this when they are in this adolescent age group, when they are 13 to 15 years of age, is when a lot of these patients may start. And nowadays, there's more than just the cigarette smoke. We have, obviously, there's some edible tobacco, or the chewable, tobacco, there's cigars, but there's all these new vaping products that we see. And the vaping products are particularly worrisome because there's not always the same exact ingredients in there. They're very different based on the brand. The main thing that we know is there's a lot of nicotine in them. There's many of them have the refillable cartridges, which have concentrated nicotine. And so this isn't only worrisome for the adolescents who have this nicotine content for their addictive potential, but for younger children who may accidentally get into one of these replacing cartridges, because it's so concentrated that if children get a mouthful of some of these, they can actually get nicotine toxicity. Most of the time when patients are smoking a cigarette or vaping, they don't really have nicotine toxicity. There's not enough there in terms of what they're exposed to for the most part to cause those symptoms. But younger children can get that more easily, especially even just chewing on a cigarette butt. And so it is important to recognize that not only is it an addictive and chronic health hazard for adolescents who are starting, but can it be an acute hazard or a very, very quick onset hazard if they get into some of these products. Alcohol is something that we are all familiar with as well on some way, shape, or form. This typically acts as a depressant. We know that we get it from multiple different fermentations of sugars, fruits, vegetables, and grains, and there's a lot of different variety when it comes to the alcohol that we can get exposed to. We have beer, wines, your liquors, but alcohol is in more than just what we typically will consume at a bar. Alcohol can be in mouthwash. Alcohol is in things like your vanilla extract in the kitchen. Alcohol is in your hand sanitizer. So there are lots of other forms and products that have alcohol in them that are not meant to be consumed, but they can be, depending on the desperation of the patient. And we know the effects of alcohol. We know that it acts as a depressant, so the reduced tension, reduced inhibition, and coordination. But depending on that blood alcohol content and how much they have in their system, this can really affect their ability to breathe, their ability to stay awake. And so patients who have very high blood alcohol content have decreased respiration, so decreased ability to breathe, and they could potentially even go to coma or death. We all know that the legal limit of alcohol when you get pulled over or they're looking to see if you're intoxicated with a breathalyzer is 0.08. And that translates to, in another set of units, 80 milligrams per deciliter. We have good evidence to show that you start getting reduced inhibition and muscular incoordination around 0.05 or 50 milligrams per deciliter. So you can start having his effects before you even hit the legal limit. And then when you get to really high levels, such as 0.4, that's when you get into the coma type area. However, the blood alcohol contents are only valid in terms of the effects that you will definitively see in patients who are naive and don't have a big tolerance to alcohol. When you get into patients who are chronically drinking, whether they be older adolescents or adults, they have tolerance to this. And so a blood alcohol content of 0.05 for them might be nothing. They might be absolutely fine. They may not feel the effects until 0.09 to 0.1. It really depends on how much they're actually drinking. The record alcohol content that I've actually seen and in taking care of a patient was 1.0. It's actually immeasurable, greater than 1.0, or 1,000 milligrams per deciliter. This patient came in already with an elevated alcohol level. He was a chronic drinker, and he was in his late 20s, early 30s. He came in with a blood alcohol content of around 600 milligrams per deciliter, or a 0.6. And he was concerned he was going to go through withdrawal. He had been drinking a bunch, but he ran out, so he checked himself in. And then he drank all the hand sanitizer in the emergency department room that he was in. And his blood alcohol content skyrocketed. He had to get intubated, put a tube down his throat to help him breathe for a few hours. But he was only needed it for a few hours, and he came back down and he supported his airway again. And so you can definitely develop a lot of tolerance to this medication. Opioids, something that is in the news, discussing with the government, discussing with all these different policies, because we have an opioid epidemic. Opioids are extremely common and easy to get to. We know that they work on opioid receptors, and these opioid receptors do a lot of things. Not only do they give you pain relief and euphoria, but they affect sleepiness. They can decrease your breathing rate. They also cause constipation, and you never actually can get tolerant to the constipation, although you can get tolerant to some of the other effects. And this is another important point to make, again, regarding prescription medications, because a lot of the opioids that you can get to are starting off as prescription opioids. They're starting off as something that is legally given to you, and unfortunately they become addictive or dependent on this because this affects the reward pathway. And then these patients result in what we call an opioid use disorder once they become dependent on this. I actually was able to speak with a patient. She was around 25 when I spoke with her when she came in, but she did share her story because there are programs, to get into opioid use disorder treatment, and we were discussing that with her. And she expressed how she started using opioids when she was around 13 years of age. And this is because her father had cancer and he wasn't doing too well. He had some prescription opioids to help ease his pain. And it was tough for her and her family, as we expect it would be. And she discussed and told me how she took one of her father's pain medications because she saw and was intuitive enough and noticed how it took away his pain to an extent. And she had a lot of pain from everything her family was going through, and she took one of her father's pain medications. And she said it helped. It gave her that euphoric effect. It kind of helped out with the depressive state that she was feeling and the pain associated with depression. And she would slowly just sneak her father's medication because he didn't use it all the time. And so that slowly evolved into more and more use, into more and more diversion in other circumstances, and then ultimately when she wasn't able to get any more of the prescription opioids and she didn't have a prescription for herself when she was in her late teen years, she turned to heroin, and it just spiraled down from there. And so it's not uncommon to see adolescents who are starting at this age, even adolescents who have a prescription themselves with a sports injury. There have been studies to show that patients who receive these type of prescriptions from one emergency department visit have a certain increased likelihood of potentially developing an opioid use disorder in the future. How likely that is, we don't necessarily know. There are some preliminary studies that are out there. So it is important to recognize that it's not just the heroin that we see, but it's also prescription opioids. And this is why naloxone, or the antidote, an antagonist of these receptors, has been so important for access now, because we're trying to give this to high-risk people and make awareness of what we can use for patients who are presenting in this fashion. Inhalants are a unique type of drug of abuse. I think the first three that we talked about, nicotine, alcohol, and opioids, are the three big ones that we discuss when we think of some type of use disorder or an abuse potential. But inhalants can actually have, can be more common than we think of. They're typically, we call this huffing. We typically think of it with various products that have solvents, gases, and nitrates that you can inhale, and they very quickly produce mind-altering effects. It very, very quickly goes into the brain and causes a high for the patient. And a lot of these, we have things like paint thinners, glues, different aerosol sprays. And so these patients can huff something in a very closed space, closed environment, to get as much of it as they can. Within minutes will have effects. But then unfortunately, well, unfortunately for them, it doesn't last very long. And so the high is very quick onset, very quick off. And so they'll often huff multiple times in a row to maintain their high and to keep the high going. What we're concerned about, especially from medical professionals, is the sudden sniffing death syndrome. And this is something that you may or may not have heard of before, but patients who huff or are abusing these inhalants and different solvents, what happens is their heart becomes sensitized to adrenaline based on what these chemicals can actually do to the heart. And so patients who are startled, for example, if they're huffing at home and their parents come home early and they get that big rush of adrenaline that comes through, and normally their heart rate goes up and their blood pressure goes up, that fight or flight response. And normally it's okay. We've all been there. We've all experienced that effect. But the heart, in this case, from using these drugs of abuse and these medications, is sensitized to that, and you're more likely to go into an arrhythmia. Your heart's more likely to not function appropriately and to not beat correctly. And these patients can drop very quickly. Patients who are huffing behind a gas station and the police come and find them and they take off running and then they drop because their heart is sensitized to their own adrenaline. And this is important because it actually can change how we manage the patients from our standpoint. If they come in and we're doing CPR on them, a major medication that we give for these patients is adrenaline or epinephrine. I don't want to give them any more of this if that's what caused them to go down in the first place. And so having a good history is important for managing these patients, but there's also long-term effects that we have to worry about besides just that sudden sniffing death syndrome, because patients who are chronically and consistently huffing these inhalants can have long-term brain and nerve damage. And this can manifest in anything from memory deficits, behavioral changes, mood changes, and then also other types of nerve damages that can happen. And here's an example of someone who was huffing some gold paint. Said that apparently the metallic paints give a better high. Would not know. Now we have marijuana, another really common drug of abuse, and I kind of divided this up into natural, or what we would actually get from the plant, marijuana, and then after it's going to be synthetic cannabinoids. And so marijuana, we typically think of it as being used for the anxiolytic effects, right? We have a relaxed mood, a little bit of, I guess, nervous system depression. People kind of consider it to be similar to alcohol, and that the effects that they're trying to get from it to a certain extent. We all can kind of picture the patient, the glazed over eyes, that's considered to be high from the marijuana, whether they're eating it as an edible or they're actually smoking it. But there's potential for the opposite effects. So marijuana works on what's known as the cannabinoid receptors in the body. And we have different types of cannabinoid receptors, and we have them in different areas of the body, whether it's in our brain or in other parts. And so the effects of that can vary based on how strongly something is binding to them and also how much is there to bind to them. And so that's where if you have a patient who, has never done this before and they eat an entire edible candy bar where a serving size is an eighth of a candy bar, they're going to have a very different time than someone who ate the serving size of that candy bar. There actually is a New York Times author, journalist, who went over to Colorado when they were first making all of this stuff legal in the state, and that's what happened to her. She bought some type of edible bar or edible candy bar to eat. She didn't read that only an eighth of it was the serving size. She ate the whole thing and then had an absolutely horrendous experience in her hotel room that you can read about, where she was constantly hallucinating, thought that she wasn't going to make it out. She ended up, she was fine afterwards, but it was a scary sensation and scary feeling for her because this was not the effect that she was trying to get. And that's because she had so much of it in her system and so much affecting those different cannabinoid receptors. And we also have memory problems that can develop besides just those acute effects. We do know that patients who chronically are ingesting and smoking marijuana can have IQ deficits, potentially. And the smoke, just like in cigarette smoking for tobacco, is irritating to the lungs. And you still have the same issues of cough, chronic phlegm production, increased risk of infection. And there actually have been some new studies demonstrating that patients who smoke marijuana, not edibles, but who smoke, have increased risk of cardiovascular effects, just like tobacco smoke. So we do think that the smoke is a common denominator and an important concept that we should be staying away from for our overall health. Now, synthetic cannabinoids are a bit different. A lot of people think of them as just being synthetic marijuana, fake or man-made marijuana. But there's so much more to them than just that. The common names that we think of are Spice or K2 as some of the street names. They were marketed as these two street names when they were first emerging. But this is not marijuana. These substances were actually initially made to study the cannabinoid receptors. And they were made in places like Harvard. And they bound so tightly to those receptors compared to naturally derived marijuana. And they got out as drugs of abuse. Other people make them. And there's so many chemicals. In fact, the FDA can't keep up with how many of these chemicals that there are, because once they find a set of chemicals and they ban them, the people who are making this and synthesizing it just make some alterations to the structure and they release new ones. And what they do is they take these chemicals that are man-made, these structures, and we don't always even know which ones they are. There's so many of them out there. And they spray them on inert plants that have no other psychogenic, no other effects, just basically grass. They spray them on the plants, and then they let that dry, and then they dry up the plant material. And it looks something like this with a Scooby snack. So it looks like it's a plant material, but the plant itself is doing nothing. It's whatever chemical they sprayed on it is going to be what's giving you those effects. And there's no good dosing for this. They're just spraying with a spray bottle on the plants, so you don't really know how much you're getting either. And they get around the legality of this because they don't market it for human consumption. They market it for potpourri or for aromatherapy, as we can see here from this image. And because it binds so much tighter, you have a lot stronger effects on that cannabinoid receptor. Things like extreme anxiety and hallucinations, rapid heart rate, seizures that can affect your kidneys and result in kidney failure. And what I'm really concerned about is high temperature or hyperthermia, because these patients can get so agitated that they have so much muscle movement that their temperature can skyrocket. And patients who have temperatures of 106, 107 degrees Fahrenheit, they can't survive for very long without being cooled down because their body just can't handle that. Our own proteins and structures that make up our body become denatured and they start to break down. And so the record that I've actually seen was 110 degrees Fahrenheit. The patient did not make it. He had a lot of issues that happened afterwards. But this is really concerning when you have the patients that have such extreme anxiety and hallucinations and seizures, a lot of just muscle contraction that causes the increase in temperature. So patients who are acting strange or acting extremely altered and hallucinating, cooling them down and getting a temperature on them is going to be one of the most important interventions. And here are just some other examples of the very fun and colorful packaging that you can see with these synthetic cannabinoids. And then finally, we have stimulants. And I'm grouping this in after the synthetic cannabinoids because it's a very, very similar effect. We have a wide variety of stimulants. We have things like cocaine. We have amphetamines, which include prescription medications. Adderall and Ritalin can be abused. We have MDMA, which is ecstasy. We think of at going to raves and parties. And then the bath salts that we all can remember, that Florida man who ate someone's face off. They thought it was bath salts. It actually was not bath salts. There were no bath salts in his system. But they all have a very similar structure and a very similar effect. And that effect is the same, very similar effect as the synthetic cannabinoids of increased heart rate and blood pressure, hallucinations and paranoia, seizures, and then ultimately increased temperature. And once again, cooling these patients down and getting a temperature on them is going to be really important. Another important thing to mention are all the counterfeits and contaminants that have been across the country, really, in the news. And this is especially important for adolescents and patients who are getting things off the street because we don't know what's in them. There's so much fentanyl that's contaminating things, whether it's actually contaminating heroin or contaminating oxycodone or Percocet tablets you get off the street, or people who are just trying to buy ecstasy or Xanax. It might be contaminated with fentanyl. And so here is just an example of someone took some sugar and they have what a fatal dose of heroin is in someone who does not use opioids, a fatal dose of fentanyl, and then a fatal dose of what's known as carfentanil, which is just a derivative of fentanyl. It's been used as a large game or elephant tranquilizer. And so it doesn't take a lot to cause severe effects from this contaminant. And then last but not least, I want to talk briefly about essential oils because this is becoming a very popular topic in patients who are using this, whether it's families using it in their home and they're having little children or pediatric patient populations getting into it, or adolescents also using it for some type of aromatherapy type use. And so a lot of these are just solvent-based, or they're very oily type substances. And they pose a risk if someone were to drink it and they cough it back up and it goes into their lungs, or they aspirate it. That would be just a general risk of any type of solvent, any type of very, very oily substance like gasoline that would cause an issue. So a lot of them we don't necessarily know that will cause systemic or whole body effects, but some of them we do. They all have the risk of that aspiration if they are ingested by mouth. But some of them can very specifically cause systemic effects. Oil of wintergreen is a perfect example. Oil of wintergreen smells wonderful, but it actually can cause the same toxicity that we see with aspirin, and you don't need a lot of it. In fact, a mouthful of oil of wintergreen in a child who's less than 6 years of age, or a pediatric patient population, can be enough to kill them 2 times over. That is how concentrated oil of wintergreen is, and that is how severe that toxicity can be. Pennyroyal oil has been used for many years, a lot of different reasons, but especially chronic use or very, very large ingestions can cause liver toxicity. And so there are some of these essential oils that, depending on how much they're getting into or if they're being used chronically, can cause severe toxicity that we need to manage in a healthcare facility. But there's still a lot that's unknown. There's still a lot that we're learning about, and we do have resources at the Georgia Poison Centers who look up this information. We have toxicologists on call 24/7. We have poison specialists who are going to be the ones to answer the phone, also on 24/7, and we have good resources to check for that. So when in doubt, especially with an essential oil, give us a call. Now, if we have an exposure that occurs, whether it's in a pediatric population, whether it's an adolescent population and it was an intentional abuse, call the Poison Center if we're suspicious for this. If you try to Google it, there might be inaccurate or outdated information on there. Home remedies oftentimes don't work. They may not be effective. there may be things that we can offer you as a home remedy to do. For example, button battery ingestion. There was a recent paper discussing giving honey, a couple tablespoons of honey, to help decrease the damage of the button battery on a patient's throat if they swallowed it. And so there might be home remedies that we recommend for that very, very specific purpose, but many times there's not. And then do not make anyone throw up. This used to be a common thing. We used to have syrup of ipecac, and it used to be available, and if you got into anything, you would just drink some, and it would make you throw up very forcefully multiple times. This is not recommended. It is an aspiration risk. Some of that can go into your lungs. There's dehydration associated with it. People can tear their throat or esophagus from how violently and often they are actually vomiting. And so we do not recommend this anymore. If the patient, however, won't wake up, if they have a seizure, if they stop breathing, or if they collapse, call 911 first. We are going to be here 24/7, 365 days a week. But if that patient, if we are concerned anything critical at all, call 911. And so here's just some quick poison first aid tips depending on how the patient got exposed. So once again, if they swallowed the poison, don't make them throw up. Don't give them anything. Call the poison center. There's a lot of times when you call us and we're going to say, okay, sounds good. If they didn't have enough to cause toxicity, they just got a mouthful of it, give them some food and water. Dilute what they had. It'll make them feel a bit better. It might help if they have some abdominal discomfort. But there's other things like gasoline or solvent ingestion where we're worried about that coming back up and aspirating into the lungs. And so we'll actually recommend not to give anything to eat or drink. So depending on what that ingestion is, we might tell you it's fine to eat something, we might not. If someone is inhaling something, first thing to do, remove them from what that is. Get them fresh air and call the poison center. It might be something we need to take you into the hospital to observe. It might be something where we just call back in an hour to see if your headache has resolved from whatever concentrated exposure you had. If anything's on the skin, remove the contaminated clothing. Remove the patient from what could get on the skin anymore. Remove any contaminated clothing, and then wash that off with water. You might need soap and water if it's something really oily, but a lot of water for 10 or more minutes. Decontamination is really, really important. We just want to stop that exposure and then give us a call. And finally, if anything gets in the eye, everyone's very sensitive about the eyes. First, take out any contacts if the patient has contacts in. I always have to remind myself that. And then flush the eye with lukewarm water for 15 minutes. And this is going to seem like a really long time because even water in the eye is not comfortable. Children especially, you might have to wrap them in a towel and just kind of situate them under the sink a little bit, obviously protecting their nose and their mouth to help really flush out that eye. But that's going to be the most important thing. Once again, the theme here is decontamination, getting them removed from the source is going to be really, really important. But once again, give us a call if you have any questions. We have our direct number, 404-616-9000. This gives you right to the Georgia Poison Center. You don't have to go through anything else. If your area code is not from Georgia, you might get put to another poison center, and they can give you just as accurate information as we can, but it might not be the Georgia Poison Center if your area code isn't from Georgia. We have a website, georgiapoisoncenter.com. You can also visit. And then our 1-800 number is 1-800-222-1222 if you want to call that, or the 404-616-9000. But thank you all for listening, and feel free to reach out if you have any other questions.